I am thrilled to be moderating our last session and to be joined by four healthcare experts for a very lively conversation. I am joined by Robin Rudowitz of KFF, Emily Halubowicz of the American Heart Association, Dr. Tori Mack of the Children's Hospital Association, and Dr. Julie Yarrow of the ProMedica Charles and Virginia Hickman Hospital. Thank you all so much for being here today. We have a lot to cover, so I want to jump right in. We've heard a lot in recent months about the impact of congressional action here in Washington, not just the One Big Beautiful Bill, but also expiring Obamacare subsidies, potentially expiring Medicare telehealth services, things like that. Dr. Yarrow, I want to start with you. Hospitals have been dealing with significant issues in terms of access to care over the last several years. Recent legislative action is just compounding that. Can you just paint the landscape for us a little bit? What are the main issues when it comes to patient care for your health system?
So I'm over a 58-bed rural hospital in Michigan. I'm also an internist. Good old-fashioned dinosaur where I actually did private practice. I saw patients in the outpatient world, the inpatient world, and the long-term care, and those days are over. And that was the first hurdle. When we started to see a different delivery model and care transitions, we went from people doing a jack of all trades, which we need in rural hospitals. We need generalists. And our education system right now, we are seeing more and more specialists. So probably one of the biggest hurdles I saw in the beginning of my career was a lack of generalists. We need general surgeons, general cardiologists, general pulmonologists. And so what that has caused us to do is look at different ways to deliver care. Telehealth was one of them that you mentioned, that allows us to bring specialists inside our four walls, but it doesn't replace people. I have an aging population, so they come with multiple comorbid conditions. I also am in a rural area that I have a lack of resources. So my ability to transition care, to transfer somebody to a long-term care facility, home care, durable power of medical equipment, I have limited resources, which can really delay treatment, delay care. But probably our biggest impact, cost has been talked about. I don't need to repeat everything you just heard. I would echo everything about the finances. And being creative and thinking outside the box comes with cost, particularly when payers don't pay for that creativity. But again, in a rural health environment, we try to say it doesn't matter what your zip code is. We deliver the same high quality care that someone gets in an urban area. What we stabilize and transfer out, we do for all the right reasons. So we really need to look at healthcare about treating people. We all bleed the same color. It shouldn't just be about how we're going to pay for that healthcare, but what are the outcomes and what are the safety issues we need to address.
And Dr. Mack, I want to come to you next. I think you probably deal with a lot of the same issues that Dr. Yarrow touched on. But when it comes to caring for our youngest population, are there other issues or like workforce shortages what are the most pressing challenges that are unique to pediatric care, would you say?
Thank you so much. So Children's Hospital Association, we represent 220 children's hospitals across the country, and certainly they care for children in their hospital walls, but also regionally, nationally, their centers for referral. And so when we think about the unique challenges for our children's hospitals and for children in this country, I would think about it in terms of coverage, which we talked a lot about today. Mm-hmm. But specifically when we talk about kids, we're talking about 37 million children who depend on Medicaid, right? That's a large number. When we talk about rural, it's 41% of rural kids depend on Medicaid and CHIP for their coverage, which is really important when we think about sort of pediatrics. That's a really key distinction when we talk about that. I think the other pieces, of course, are capacity. So coverage, capacity, coordination. From a capacity standpoint, to your point about workforce shortages, right? We know they're prevalent. In contrast to the adult world, we actually see a lot of pediatric subspecialty sort of shortages. Mm-hmm. One example, I know the senator was talking about behavioral mental health. When we think about across the country, there are 15 child and adolescent psychiatrists per 100,000 kids in this country. That means when we think about communities, that's 72% of counties in the United States that don't have one at all. So these workforce shortages are really, really prevalent, and they impact care for sure. And the last piece in terms of a challenge is certainly that coordination piece. And so when I think about coordination, it's really about how hospitals work with all the places that children touch, whether that be schools, rural hospitals, and sort of how they all link and work together so that no family falls through the gaps.
It's interesting that you face some of the same challenges, but also different in terms of generalist and specialist. When I was preparing for this panel, I read that statistic that you had provided about child psychiatrists, and it was just astounding, you know. I want to turn to congressional action, what we've seen this year, what might be happening later this year. Robin, Dr. Mack touched on how many children are dependent on Medicaid for their health care, especially in rural areas. What are some of the real world impacts from KFF's perspective of the One Big Beautiful Bill and other legislation that Congress is considering or that might be expiring?
Sure. So the bill included about $900 billion in reductions, federal spending reductions for the Medicaid program over the next 10 years. Congressional Budget Office estimates that there'll be 10 million more people uninsured as a result of the provisions in the bill. So these are major impacts in the overall healthcare system. So Medicaid, as we've heard, provides a huge complex role in the healthcare system. It's coverage for 1 in 5 people overall, 1 in 4 people in rural areas. It's 50% of births are financed by the Medicaid program in rural areas. It's the largest piece of financing for states. So states are really going to have to deal with some of and make very hard decisions about how to manage with less federal dollars. So I think the coverage impacts as well as the financing implications will have broad ramifications for states, providers, and for people who might lose access to coverage.
And I want to get to in just a minute some of the real world implications of having to make these decisions soon. But Emily, first, I want to bring you in here. Do you think that the public understands the impact, the potential of 10 million more people being uninsured over the next decade, the impact of these potential cuts, and how it could affect their health care and their access to care?
Well, thank you, Heather, and thanks for that great question. And just for a little bit of background, the American Heart Association, we're now in our 2nd century. We really sit at the nexus of medical research, quality care improvement, patient engagement, and advocacy. I lead our federal advocacy team here in Washington, D.C., and for more than 40 years, we've been advocating at the federal, state, local level for enhanced and more affordable access to care. And so to answer your question, I would say yes and no. I think for the more than 100,000 advocates in our heart-powered grassroots network, they understand very acutely how important access to care is and how important Medicaid is to getting that affordable access. But I'm not sure that everyone, and especially here in Washington, always understand that what we're talking about are more than budget lines. These are lifelines. These are issues of life and death for many people in America. I would say, given the public engagement around the enactment of OB3, we saw our own advocates, thousands taking action. We saw tens of thousands of people in America taking action. I think many do understand what this means, but many unfortunately do not yet. They will certainly feel effects soon. Unfortunately, once these changes go into effect, it may be too late for a lot of individuals, and it may be too late for a lot of these healthcare institutions, especially in rural areas, who are going to be feeling the effects most.
Yeah, and I think we were talking a little bit about this behind the scenes before going on stage, but there's a ripple effect here for everyone's healthcare, right? Even if you are not one of the uninsured, the impacts of that will touch you too. Dr. Mack and then Dr. Yarrow, I want to go to both of you. Senator Welch, he said a lot of these cuts aren't immediately taking effect, but hospital administrators are seeing over the horizon and making adjustments now. Are you seeing that in your systems, and what does that look like? Dr. Mack, I'll start with you.
Yeah, absolutely. I think children's hospitals are always trying to fill in the gaps, been forced to be innovators from the beginning, and so are always forward-thinking and forward-looking in terms of what kind of solutions they can find. And they're looking for them, right, and sort of putting them into action, and particularly when we think about sort of rural communities and rural hospitals, the ways children's hospitals are sort of filling that gap in is helping to provide that care. And we think about some of our hospitals, which again are catchment areas. We'll take Intermountain Primary Care in Utah, right? They have a huge region, right? They're serving rural communities all the time, and they fill that gap with a lot of telehealth, right? And so how they are able to work with adult ER physicians who see children maybe more infrequently than they do, sort of equipping them with the training that they need, but then also the telehealth services to help them in real time. And so there are ways that certainly children's hospitals are thinking over the right horizon and trying to find solutions, but of course, a lot of that is not reimbursed, right? And so when we think about Medicaid and the need for reimbursement, it's key. Also thinking about those specialist providers and even the general pediatricians. Children's Hospital Graduate Medical Education, right, gets about half the funding of adult GME, and so it's really critical to think about how we're continuing to fund this, and then also incentives for pediatric providers to be in place. And so children's hospitals are certainly trying to fill that gap, but of course, need the funding and the scalability to be able to do so.
Right, right. And Dr. Yara, what's your experience with kind of looking over the horizon, as Senator Welch said? And
So there's been many disruptors in healthcare, and I'll just point out hospitals keep their doors open. So when your disruptors close, the ripple effect is those patients come to our emergency rooms, and that affects everybody. It doesn't matter what your payer is. You will have longer waits. We will need more beds to transfer those patients out once we stabilize them. So we've been dealing with this for years. But I unfortunately have had this sad choice of closing a mental health unit because I didn't have providers. I didn't have the payer mix that I needed. Over 80% of my inpatients are governmental payers. That affects my bottom line. That inhibits me from keeping other services, as you heard, lose money, like labor and delivery and mental health open, so my community has access. And the great thing about healthcare right now is we don't practice healthcare like we did 20 years ago. Minutes make a difference. And so I need access to care because I can improve outcomes. I can save people, improve their quality of life after strokes, after heart attacks. That means I can get them back into your community, back working in your industries. So we really need to look at that access and how we deliver care and how we can improve outcomes. And so we've been dealing this with forever. Again, we use telehealth, we use robotic, we use ambient listening to decrease pajama time for our providers so they don't have burnout. But there is a massive shortage out there of providers, greater than 1 million nurses predicted in under 10 years. I have a loss of respiratory therapists, pharmacists that I have job openings for greater than a year. So we need to not just look at the finances too, we need to look how we're going to build the next generation of healthcare and make those solutions that we can also get paid for.
And you talked a lot before we came on stage about governmental payers, and I know you've mentioned it a few times here. Can you elaborate just a little bit for those in the audience or maybe on the live stream who don't understand the importance of that and how those two work together, why that's so critical?
Yeah, so many rural hospitals have a higher governmental payer mix than many of our urban counterparts. So for my inpatient volume, I'm over 80% governmental payers, so that's a mix of your Medicare and Medicaid. I'm also a Medicare dependent hospital, which is always something up for discussion whether or not that will continue to stand. Losing those type of benefits can close more service lines in my region. I also, from an outpatient standpoint, I have a high Medicaid population. When you lose that funding, patients no longer come and seek care. Outcomes are poorer. People wait until their illness is to the point that I can't save them. Compliance goes down, readmission rates go up. So there's a story that goes beyond just receiving that initial payment. There's a story about how it affects that community and what solutions that we have to address that.
Thank you so much. I appreciate that. And I want to turn to the Rural Health Fund. We've touched on that a lot in our conversations this morning. Robin, I want to start with you. Senator Welch had some very colorful words. He said totally absurd, that it'll fill the gap, magical thinking, bogus. Mr. Lassiter said completely disproportionate, will not save America's rural hospitals. Do you agree with those assessments? What would you like to add?
Well, I mean, I do think we've done some analysis at KFF, and when we look at the $900 billion in reductions in federal financing for Medicaid, we've done some estimates that translates to about $137 billion in reductions in Medicaid to rural areas. So, I mean, before there was the comparison of the $1 trillion, but We looked at the 137 billion that would be Medicaid reductions in rural areas. So clearly that is quite a bit larger than the fund, the $50 billion fund. I mean, in our analysis of the fund, I would echo some of the comments that were made that the fund is temporary, so it's time limited, whereas some of the reductions that are in place in the bill are much more permanent, built into the healthcare system. And there's many, many uncertainties about how that the dollars in those funds will be distributed across states and to hospitals, whether they'll all go to rural hospitals, whether they'll all go to rural areas. So I think there's a lot of question and uncertainty, and certainly the magnitude of the fund is much lower than the reductions.
And Emily, I want to bring you in here. Cardiovascular disease is still the #1 cause of death in America. I'm not sure if you had polled America, if they would know that, even though it has been for a long time. When you see these dramatic cuts to healthcare, particularly rural hospitals, how does that impact the treatment of cardiovascular disease? And how is your organization approaching these potential cuts and things like that?
It's a great question. Many Americans do know that. It is the leading cause of death here and around the world, but many do not, and that's part of what we do at the American Heart Association is raise awareness and help people understand their own risks. To your question about what this means for patients, frankly, it just makes it harder to get access to care. Certainly the cuts that we're expecting in Medicaid and the coverage losses in Medicaid are going to have a devastating effect, particularly for those in rural areas where we know based on data that rural residents are 30% higher risk for stroke, 40% higher risk for cardiovascular disease. But there's more imminently coming. We have 2 cliffs that are approaching. We talked a little bit about the telehealth waivers that are expiring at the end of this month. Telehealth is healthcare. It is fully integrated into our healthcare delivery system, largely because of COVID. But I think the idea of taking that away and taking that access away would make it only harder. The other cliff, of course, is the premium tax credits that are expiring at the end of this calendar year. But really, the impact of that will be felt sooner as plans need to put out their rate notices before open enrollment. It's an area where we're really engaged with others in the patient community to ensure those are extended. Estimated 4 million people, according to CBO, will lose access to their care. Just this morning, AARP released a report that nearly all of individuals in the marketplace, ages 50, 64, my age group, rely on those premium subsidies. This will have absolutely devastating effects, not just for those on the Affordable Care Act, but across the health system. Anyone who experiences insurance will see their premiums go up. And in fact, I think KFF's analysis said 75% increase anticipated if those premium tax credits expire. So all of this means less affordable care just means less access to care, and it will lead to worse health outcomes.
And I think you touch on a great point when it comes to the ACA subsidies, which is what we've seen. Democrats, and we've reported on this a lot at Punchbowl News, are trying to get the word out there that yes, these expire at the end of the year, but these premiums are going to increase far before then, and we really need to address this now in this government funding bill. That's the position that they're taking. I'm not sure how far that's resonating beyond Washington yet. That's kind of part of the reporting that we're doing, but that is definitely, when you talk to them on the Hill, the message that they're trying to get out. Dr. Mack, I want to go to you. As Emily said, there are some telehealth provisions expiring at the end of this month. I was really interested in reading the notes before this panel about how critical telehealth is to pediatric care, especially in rural areas. How closely are you watching the action on the Hill, and what kind of impact would this have on the children that you treat?
A huge impact, and thank you for that question. I do want to touch upon quickly what she shared because I want that to be underscored too, just in terms of the allied health professionals, right? The respiratory therapists and the huge gap there, especially as we're entering respiratory season is huge. Children's hospitals, 2/3 of them are having trouble filling respiratory therapist positions, 40% don't have imaging techs, and that's really critical right now. So to your question specifically around telehealth, children's hospitals, of course, certainly during COVID, have used telehealth more and more, but have seen the benefits, particularly when we think about rural communities, right? There are really specific examples, not only of how they're used in hospitals, but even every place where children touch. So school-based health clinics, for instance, the ability to bring telehealth into school systems and be there with the parents and treat kids there, keeping them in school, right?
Yeah.
These are really important things, right? And this happened at Cone, Women and Children's Center in North Carolina. They were able to see 300 kids
Wow.
fairly quickly. 240 of them were able to stay in class. That's really impacting their well-being. So that is something that's critically important. But then also, those other 60 were able to be seen in the ER, right? And it's really important, especially as we think about the impacts, to your point, about people being sicker, certainly in rural communities. We see that in pediatrics as well. When they come to the emergency room, when they come to see their doctor, they're more ill, they have to travel further. And so the ways that we could think about sort of shrinking distance with telehealth is really critical.
Yeah, and you make a great point that being able to see patients via telehealth impacts other patients coming to the ER who need to be seen in person, right? And can be seen faster and quicker. Dr. Yara, I want to go to you on these issues. We've talked about the expiring Obamacare subsidies, the potential healthcare telehealth provisions that might expire. From your perspective and your health system, how alarmed are you by the inaction so far on the Hill, and what would be the impact for your hospital if some of these things weren't extended?
So I'll hit on the provider tax that was mentioned. So in my state, the provider tax has been instrumental in keeping services open. I think without it, one of our smaller hospitals would close, another inpatient mental health. Again, a ripple effect. That means people are sitting in the ED for longer periods of time, not getting treated in crisis. It's really happening out there. Labor and delivery probably is another service line without provider tax dollars that we would see greater closures across America. 8 labor and delivery units in my state alone have closed recently. You know, the telehealth provision, again, it's not the end-all solution to healthcare and rural health. I'll just say that. Because you still need a provider on the other side of that monitor. So we still need people. There's also a lot of technology that we talk about that telehealth is phenomenal. We can give people monitors that they can put up to their heart and their lungs, and we can auscultate from 200 miles away. But that comes at a cost. And many of my patients in rural environment can't afford that technology or still have bandwidth issues. So again, we need those dollars to continue to be able to supply that innovation to those that need it, that are most crucial, that travel over mountains to get care, to travel. I'm 750 square miles. People have to travel over an hour just to get to me. If I cannot provide that care, they travel another 45 minutes to get that care. So this technology, this funding is making care accessible no matter what zip code you are. So if we lose that funding, I'm looking at what more I'm going to close. I'm looking at other innovative solutions, but chances are they're also going to come at a cost.
Right. Robin, I want to turn to you. KFF has done some polling on adults in rural areas, their concerns about access to care, things like that. I was hoping you could share some of the top line findings for this group and those on the live stream.
Yeah, I would say our polling shows that individuals in rural areas are already quite concerned about lack of access in terms of hospitals, behavioral health, being able to see a physician. And overall, I find always these statistics pretty staggering that over half of people in the country and in rural areas have some connection to the Medicaid program, so they themselves are covered, or they have a child, or have been covered at some point. And that statistic goes up to 2/3 of people when they know themselves or a close family friend. So the program has really wide reach and really broad favorability across political parties. So makes the impact of some of these changes very personal for people. And also staggering in some of our polling is that nearly all, 97%, which is a very high number for polling, say that the Medicaid program is important in their communities, and that's in rural communities also. So that means the reach of coverage as well as access to providers. So I do think to the point that many people are not feeling the implications of what is in the bill when they start to go into effect and people feel some of these implications. These are some of the base support and connection to the program. So many people will be affected.
Yeah, I mean, I was a little astounded by the numbers, just how many people say it is important. Obviously it is important, but not everyone always realizes, well, if I don't have something, is this important? But like you said, it touches so many people, particularly in rural areas. We only have a few minutes left, so we've talked a lot about the challenges. I want to turn to resilience. Emily, I want to start with you. There are several programs led by the American Heart Association to provide support, particularly in rural America. One that I was reading about in my notes before, the Rural Health Accelerator, which was just extended. Can you share more about that program and other things that the Heart Association is doing to try to provide support?
Sure, and thank you for asking. The Rural Health Accelerator, as you noted, was just extended to 2028. We started this in 2022 as really building off of our highly successful and impactful Get With The Guidelines program, which embeds in hospitals across the country, providing access to the best and most recent scientific evidence and measurement on how to improve the quality of care and care delivery. This program offers no-cost access to rural hospitals so they can access the best evidence and how to do their own improvement in quality delivery. And so we're really excited about it. It's one of the ways in which we support rural provider resilience. And on the topic of resilience, I just want to note, I think we would all acknowledge that rural communities and individuals are nothing if not resilient. I do think, though, and for years they've been doing more with less. As we look at the current environment and we look at OB3 and the potential Medicaid cuts, and none of these decisions or policy actions take place in a vacuum. Mm-hmm. If we're looking at the totality of actions at the federal level, be it OB3, or we're looking at discretionary spending cuts that affect medical research dollars that are going to institutions, when we look at cuts to state funding for public health and prevention, like smoking cessation, elimination of funding at the Office of Smoking Health, together with the rising cost of living, together with the provider workforce shortage and burnout, together with increased demand with an aging baby boomer population. At some point, you're doing less with less. And it feels like we're at a tipping point. Mr. Lasseter talked about a crisis level. It feels like we're there, especially as we look at now states who are kind of having to figure out how to fill all the gaps and the holes in all the funding cuts that they've seen. And so, yes, I believe our health system is resilient. I believe patients are resilient. But at some point, it feels like something has to give. And I think that's why the American Heart Association continues to advocate so relentlessly for policies that will improve people's health.
Right. And I think you all have underscored in talking to Senator Welch earlier and Mr. Lasseter kind of the putting a face on the impact of action here in Washington, and the real world impact of that. I know we just have time for maybe one more question. I want to start with you, Dr. Yarrow, and kind of go down the line. Looking over the next 5 or so years, what gives you hope when it comes to healthcare and especially in rural areas and access?
It's the people I work with every day. It's the people I get to care for every day. We are resilient in rural healthcare. We wear multiple hats. That's not new to us. And hopefully we will persevere no matter what the changes are. I'm hopeful that we can start becoming more of the solution. We're doing a better job telling our story, letting others understand who we are, what barriers we have in front of us. But yeah, I would say it's the people, it's the willingness to be creative, flexible, innovative. That brings me hope.
Dr. Mack?
Absolutely. I'm fortunate enough to be able to work with children in children's hospitals, and so there's always hope in that. I'm a pediatrician by training, and I always find hope in our children. There certainly are the key to our future, as cliche as that might sound. And when I think about hope that our children's hospitals are really putting forward, is all of these solutions that they've found, right? We know things that work. We know what makes kids better. And so if we can build on those solutions, we can pay for them. When we think about sort of Medicaid, we think about reimbursement, we think about graduate medical education and incentives for our workforce. We know these things work. We just have to do them. So there's hope in that for me.
Emily?
I love this question because our vision is actually advancing health and hope for everyone everywhere. And I have so much hope as I see our incredible, courageous patient advocates who work tirelessly. It is not their day job, but to share their stories, it takes real courage to share these stories, and they give me hope, and it's what keeps me going every day.
Robin?
Yeah, it is a tough question, and I think that there are a lot of challenges ahead, but I would just echo, even being on this panel, the implications of the reductions hit states, providers, and people, and clearly on the provider side, it seems like providers are going to take the challenges head on. States, I know, are already working to face the challenges of implementation of many of the provisions in the bill, and certainly enrollees in the Medicaid program and people who need their health care coverage will continue to be resilient and hopefully meet the challenges as well.
I want to thank all of our panelists today for sharing their perspectives. A big thank you to Senator Welch for also joining us for the Summit Access to Care. We covered a lot of ground in all three sessions when it comes to rural hospitals and health systems. I also want to give a big thank you to the Coalition to Strengthen America's Healthcare for partnering with us to make events like this possible. I would love for everyone to stick around. We have more coffee, bites, and networking, and have a great day. Thank you all.